Hello and welcome to the Days of Learning podcast. I'm your host, David Nelson, and I am just thrilled to say hello to my guest and someone I've been looking forward to speaking with for months now. And it's been a challenge to get us on the schedule together, Dr. Ivor Benjamin. Dr. Benjamin, it's so good to have you on the Days of Learning podcast.
It's wonderful to be here, Dr. Nelson. I recognize that it took a while to get on to your schedule, but really looking forward and delighted to be here. Thank you very much.
You're very welcome, sir. And let me tell the listeners about you. Dr. Benjamin received his medical degree from Johns Hopkins University School of Medicine, internship and residency in internal medicine at Yale University School of Medicine, and received fellowship training in clinical cardiology, molecular cardiology, and molecular biology at the University of Chicago, Duke University Medical Center, and the University of Texas Southwestern Medical Center in Dallas. As the director of the Cardiovascular Center at the Medical College of Wisconsin since 2013, and professor of medicine at MCW and Froedtert Hospital, Dr. Benjamin brings more than 25 years of experience leading cardiovascular clinical and research programs. Dr. Benjamin's leadership of the Cardiovascular Center at the Medical College of Wisconsin is increasing the investigative workforce as co-director of an NHLBI T32 training program, and he is building a transformative platform for centralizing clinical and translational research along with the T1 through T4 continuum with support from the Advancing a Healthier Wisconsin Research and Educational Endowment Program. Dr. Benjamin is the recipient of numerous medical honors, including the Pioneer Award of the National Institutes of Health and the Dr. Daniel D. Savage Memorial Service Award of the Association of Black Cardiologists. With a 30-year volunteer history with the American Heart Association, he proudly served as president from 2018, 2019, and then immediate past president from 2019, 2020. A highly regarded physician scientist of molecular cardiovascular remodeling, he has an AHA established investigator, a founding member of the Journal of the American Heart Association, and currently serves on the editorial boards of the Circulation and Circulation Research. As chair of the American Heart Association Research Committee from 2015 to 2017, he expanded opportunities in research for women, minorities, and undergraduates. Dr. Benjamin is a member of its board of directors, corporate operations, coordinating committee, executive committee, international committee, and science and advisory coordinating committee. He is also a longtime member of the association's Council on Basic Cardiovascular Sciences and the Council on Clinical Cardiology. And I can add that Dr. Benjamin is my friend. And so it is so good to have you on the show, sir, and to be able to tell our listeners a bit about your background.
Well, you took a while to just get to the real point. We are friends.
Dr. Benjamin, I really like to ask this starting question, and I ask it of all my guests. Tell us about your journey from wherever you want to pick up, and tell us how you got to this place of being in cardiology, as well as your place here at the Medical College of Wisconsin.
Absolutely. Well, again, thank you so very much for having me. I have likewise not only admired your professional contributions, but we've had a chance to collaborate on research proposals, and being a student of people, what has really struck me is how you not only sort of talk the talk, but you walk the walk.
Thank you, sir.
And I just want to let you know and let your audience know, of course they know this, that this is really one of the highlights of being here at the Medical College of Wisconsin. But you ask an important question, which is to tell you a little bit about my journey. And I thought that perhaps what I will do is somehow put the bookends out there, if you will. So just prior to coming to the Medical College of Wisconsin, I was at the University of Utah, where I was the division chief of cardiology, and saw this opportunity to come to Wisconsin and be the director here of the Cardiovascular Center, whose mission is committed to improving, of course, the lives through clinical care. We think that research is a key and important element to enhancing what we do. I'm committed to the training the next generation of leaders. And just as well, we need to be outwardly faced. Those leaders need to be impactful in communities. So with that as a, if you will, one side of the bookend, let me just sort of take you way back. I wouldn't tell you how many years, decades ago, but you know, I grew up in a small country. It's Guyana. It's the former British Guyana. The oldest son of 5 children, to parents who are still the apples of my eye. They're now passed on. Hope one day I'll see them again. But they had a zest for life and wanting to give the most to their children, resulted in me emigrating to New York City when I was a teenager. So finished high school, had an interest in math and the sciences. You know, part of my journey was that at age 9, my one of the most favorite women in my life, my grandmother. It actually turns out that today is Go Red for Women Day. It actually turns out that we need to celebrate all the women's in our lives and what heart disease and its impact and how we can obviously prevent that. But you know, at age 9, my grandmother, she got a stroke. Not clear to me why. So here was someone who was vibrant, healthy, was now reduced to having, the technical term is called a dense hemiparesis. In other words, she was paralyzed on one part of her side, but she then became dependent. She was, if you will, now part of my family, my immediate family. That my mom brought her in, and we slept in the same bedroom. And in fact, I helped to feed my grandmother. And that early experience, what I like to say, my grandmother was my first patient, because I begin to ask myself the question, well, why did this happen to grandma? How did it happen? Fast forward, I went on to medical school and I'm an intern, and my mother got a stroke. And by that time, of course, being in the medical profession, I was able to sort of put a lot of things together. Both of them had high blood pressure. High blood pressure is a major risk factor for a condition called atrial fibrillation. And the atrial fibrillation increases your chance of having a stroke. So although at 9, what my grandmother had, I quite didn't know. We didn't have all of the tools available. More likely than not, this is something that impacted both of them. And sadly enough, that remains something even today. So I committed myself to become a cardiovascular investigator and to be able to do the research that can potentially reduce cardiovascular disease and stroke. So that's been my interest. I'm a physician scientist. I am really passionate about patient care, but also everything that we can do, you see, to increase new insights of how we can basically reduce those risk factors. Those risk factors include hypertension, as I mentioned. They include diabetes. They include the kinds of things we have to do to increase the chances that we can be able to have longer, healthier lives. And so we know that these are areas that disproportionately impact communities of color. And I'm committed to seeing how those messages can continue to go out and be in partnership with the kinds of efforts. So I know how important you are and in the community, and you're very much part of understanding what the social determinants of health are, and we'll be able to obviously to unpack some of that. But in a nutshell, I'm a product of public education, and I've been extraordinarily blessed to have had a career that's taken me all over the world, and one for which being a father and a husband of 3 children, several of whom are in the medical profession, I just feel enormously blessed.
You know, Dr. Benjamin, I really appreciate you telling me the bookends of your story, because it is one with a thread that goes through it. And you used a phrase that I want to give back to you, that idea of your parents had this zest for life. And I like that, because even in the midst of something as heartbreaking as losing loved ones to debilitating issues like strokes, that I can imagine your parents and even your grandmother had a zest for life. Did you ever did you have an unwavering dedication at that moment, or was there times when you go, I can't figure this out, or I don't know, this is too hard, or this is beyond me?
It's an excellent question. And in my case, I'll tell you a quick story. And the story is What's in a Name? Well, I'm Ivor James Emmanuel Benjamin. The James is from one Jim Morrill, my great uncle. It turns out that Jim Morrill, my grandmother's brother, left Guyana in the late 1800s. He actually was in the United States. We was able to trace that he was some there in Battle Creek, Michigan. But ultimately, where this story goes is that James Morrill graduated from University of Edinburgh in Scotland in 1923. I was able to go and retrieve his diploma. It him triple certified in obstetrics and gynecology surgery. And it really was part of how, when I brought home good grades, my mom will say, oh, maybe one day you'll be like your Uncle Jim. That's all she said. I never felt any pressure whatsoever. As I mentioned, I've done my level best. I've got an older son who's a pulmonary critical care fellow. My middle child is in hospital administration, and I've got a daughter who is in medical school. My hope will be that when I engage with my kids, I quote unquote didn't put any pressure on them, because my parents never ever put any pressure. But that story of what's in a name. So I knew, and oh, by the way, I know this is not true for everyone. I've been right here in Milwaukee, where after giving a talk, a young African-American man will walk up to me and say, Dr. Benjamin, I just want to hold your hand, because I didn't know there was a Black cardiologist here in Milwaukee. So I am very much cognizant of the fact that my life story isn't everyone's life story. And me being able to reach out and be a role model for others, we have a real crisis in our country over the number, especially African-American men, who do not feel, because if they're medical school material. In 1978, when I matriculated to the Johns Hopkins University School of Medicine, that number who were applying to medical school was actually lower just about 4 or 5 years ago. Mm-hmm. In spite of the fact that we have more African-American men graduating from college, fewer feel that they're of medical school material. We need to do something about that. So I'm very passionate about the pipeline. I'm very much committed to seeing all that we can do. And of course, we might have a chance to talk a little bit more about the pandemic and its impact, its disproportionate impact on communities of color and what that means for for education, mental health, and the list goes on.
Your mother was, I just can envision your mother saying this too. Oh, maybe someday you'll be like, but I think that speaks to, you spoke of earlier about this idea of next generation. And I recently did a talk where we not only have to be concerned about where we are today, but where the children being born are at 6th and North Avenue, for example.
Right.
And so, and how do we give them, and I would hope that one day, your great grandchildren will say, I am a part of this legacy, and this legacy of excellence, not only in medicine, but in boosting up the health of all community members.
I think it's incumbent on every one of us to commit ourselves to leave the world a better place than we found it. And there is no other legacy than ensuring that you are doing the best that you can for humankind.
Absolutely. Dr. Benjamin, tell us about the Cardiovascular Center. Many people don't even know that what the medical college is and who we are. And certainly when you go down the path of when they see something like CVC or Cardiovascular Center, they might not have any clue. Give us a brief on what the CVC Center is about.
Sure enough. So the Medical College of Wisconsin is one of two medical schools here in the state of Wisconsin. Obviously, there is the flagship University of Wisconsin in Madison, and there is a medical school there that's a public school, but the Medical Wisconsin is a private school. It actually was even part of Marquette in its 125-year history. It's actually one of the largest private schools in the country. It now has two campuses, both in Green Bay and Central Wisconsin. It, of course, has a graduate schools, it has a pharmacy school, and many other schools that are allied profession. So what is a cardiovascular center? Well, it's in part really the hub where we bring together folks who are interested in studying and improving upon the care, as well as everything that we can do to improve the lives of people who have cardiovascular disease. Now, that membership within the center includes individuals, PhD scientists, who might be studying blood vessels. And they are using tools and technologies, whether it be cultured cells, they may have other model systems, but they're trying to understand questions that at the clinical level manifest themselves in the form of a heart attack. Well, what's a heart attack? A heart attack is basically a blockage of a blood vessel resulting in subsequent damage and death of heart cells. That is a serious problem. As they say, serious as a heart attack. Well, we know that there are several processes that contribute to heart attacks. And so people might be studying cholesterol. They might be studying what might be the pathways. And fortunately, in the last 30 years, we've got amazing medicines that can actually not only lower cholesterol, but even when there is a heart attack, medicines coupled with interventions such as sort of these clot busters, there are certainly drugs that are able to do that. More recently, time is hard, and you can get to a high quality medical center, be it Frederick, many others that are in the area, and specific specialists are able to relieve those clots doing something called angioplasty. Well, we know that heart disease is preventable. There are many risk factors: smoking, diet, exercise, hypertension, diabetes. There are individuals that are studying all of those different aspects to cardiovascular disease. So we know that it's a little bit more complex. Uh, Science and research is a team sport. So the Cardiovascular Center is a vehicle, it's a platform where like-minded folk will come together, form the kinds of analyses and alliances and affinity groups so that they can then go on and be competitive with their ideas that are peer reviewed. And they then are able, of course, once they have those findings, an important part of the scientific process, you see, is that you have to publish it. You have to communicate it with the wider audience. So we feel that as part of the scientific process of contributing to new knowledge, we have to be absolutely concerned about bringing in the next generation. And that's really where training comes in. And that's what I'm passionate about. And it's not just, scientists who are in whatever particular, we really, I think that the single most important thing that we need to be in the Cardiovascular Center is to attract the pipeline. The pipeline needs to represent every aspect of society. And so whether you're living at somewhere close by to 6th and North, you should feel one day that you could be part of contributing to new knowledge, whether it be in cardiovascular, whether it be in cancer research, no matter what it is, one has to really be able to feel, and that depends on opportunity.
We often talk about the relevancy to community. That's a relatively new phenomenon, that engagement of the community in the science. Is that correct, sir?
So not only are you correct, but I'm going to actually try to provide some context to that astute observation. Today, we talk about the social determinants of health. And of course, you shared with the audience that my bio includes being a cardiologist. Well, just imagine that we're looking at the pie, okay? And you are asked to say, well, what percentage of the pie do those of us who are in the healthcare system, what percentage of that pie do we really do to impact health? Many people will be surprised to learn that's only about 20%.
Mm-hmm.
80% of that pie, 80% of health has to do with social determinants of health and many other barriers to really being able to achieve optimal health. We call that health equity. And so those barriers are really being studied more. The social determinants simply mean about where people live, where they work, where they go to church, where they go to school. We're learning more and more about the impact of structural racism, as well as, of course, these are issues that not only impact people within urban communities, but we know that there are other aspects that will be able to prevent access to high quality care in rural communities as well. So the phenomenon that you're describing, the idea of being in the community, if we really want to uplift the entire health of communities, we get to realize that there's only so much that medicines and procedures and various devices can do. We have to be involved in reducing those barriers so that we can really achieve health equity.
You said something that really piqued my interest, sir. You had mentioned this idea of social determinants, which is where people live, the food that they have access to, the economic status that they have to, the education that they have to, and the social support that they have to. But you said something that I really want to get your opinion on. You mentioned this idea of health equity, which indicates that there are health inequities in our community. And that signifies that there is perhaps disinvestment, or that there's definitely inequality, but there are fewer resources perhaps where they're needed most. And you said something about structural racism. There are people that deny that racism even exists. And you're saying that this idea of structural racism and health inequities is a cause of heart disease and heart issues. Is that what I hear you say?
You heard me say that racism is a public health crisis.
Say
Yes.
more about that.
Well, what is the evidence? There are policies and practices, be it redlining in terms of where people would have a chance to be able to live. We have food deserts, the kinds of choices that people are forced to make just as part of daily living is not random. There are individual choices that we all make, but oftentimes those choices are influenced by other structural barriers. When you mention inequity, people, I am speaking about health equity and not health equality.
Mhm.
Equality is about giving everybody just about the same. Equity is meeting people where they are and figuring out what it is they need at that level, you see,
I
so
do.
that they can achieve optimal health. In other words, some individuals might appear to receive a little bit more, but that is the goal of equity, because if you can have as many members in society, at least giving them that opportunity, then all of us, all boats will rise at the same time.
As a person of color, when did you start realizing this? You've been in the field for a long time, sir. And so when did you start think that there was something greater to being a person of color in heart disease?
Really important question. And I think that if you were to ask anyone who has been in heart disease for as long as you have, there have been many things that we have recognized, but it takes a while for there to be the kind of collective conversation. And we talk about critical mass. This is not just true just for those of us within the health community, but the Chamber of Commerce is interested. Okay, health systems are interested. We have we it takes a while for us to, if you will, have others who will come along. And so while we all recognized the impact of social determinants, today, however, there are more voices, there are more engagement, be it public policy, health systems, certainly nonprofit organizations. I mean, as a cardiologist, as you mentioned, I've been involved with the American Heart Association, the American College of Cardiology, certainly public legislatures, and even as we go from state, local and state, and we go to, if you will, the public discourse at the federal level, there is a lot of conversation around what it is we need to do. One of the things that we clearly were able to have, and there's good evidence, when you look at what was the impact, for example, of the Affordable Care Act between states that adopted, let's say, Medicaid expansion compared with others. When you now look at health outcomes, and by the way, it also required whole new disciplines like health services research,
Mhm.
implementation research. These are areas that perhaps were in their infancy, but these are now mature areas. So you have many more um, effective and eloquent voices who can help to increase the general knowledge, not only of the medical community, but the broader community writ large.
I'm so glad that you mentioned that idea of critical mass and collective conversation. As it's Heart Month, and these will air during Heart Month, which is February, I had a chance to meet with the American Heart Association's Tim Nicolai, who you know well. And he expressed to me some of that change around moving just beyond, though heart health and cardiovascular health is important, they are now involved in such issues as food deserts, safe places where people can play, and other things that go with this idea of social determinants. And I couldn't help but think that as you describe some of this work that you guys are involved in, that you literally can take cardiovascular health from the molecular level, from the cellular level, which is exceedingly important, all the way out to the population and community health levels. And it's important that we think about how those linkages come together.
No question about that. And here is another. I'm going to digress only for a minute to say that while February is heart health, we also have to recognize that brain health, okay, is so incredibly important. And while I think we have the science and just the ways in which medical advances have occurred, we seem to have a lot more in the toolbox to treat cardiovascular disease. Brain health is incredibly important. And as you know,
Mm-hmm.
there are many neurodegenerative diseases that seem to have a disproportionate impact in communities of color. But I think that your question or your comment about the built environment also means that part of developing the team is not just, if you will, those of us who are in the ivory tower. As we think about community-based participatory research, which is an area for which you are a national and international expert, community-based participatory research of necessity means that you have to go to the community, find out from folks in the community what the big issues are, and then form those partnerships. Because through that engagement, it's more likely that the findings not only will have legitimacy, but there's a chance for validation.
Let's go down that path. And one of my questions is, how do we better connect the science and, as you said, the team, which is going to include the community, to this idea of cardiovascular and, as you said, importantly, brain health? So how do we connect the two?
We're doing that right now, right? Um, I think that we simply need to be relentless in our commitment in demystifying what it is we do.
Mm-hmm.
We have to engage. We have to speak and engage with our various communities as part of a collaboration. There needs to be more voices. the influencers in the community should also be at the table. We really would be remiss if we did not address certain fundamental issues around mistrust.
Mhm.
And we know that this is an issue because as we are still, as we speak now, in the midst of a global pandemic, and even with highly efficacious vaccines that are available to mitigate serious illness from an agent that we can't see, but whose number one mission is to kill. That's what, the virus's business is exactly that. But,
Replicate.
that's how it will survive. But we have to make it our business that we want to live. Life is vital. It's vital for ourselves, it's vital to those around us who we love. And so mistrust of information and mistrust of not just the medical community, but these are barriers to what we now know and call vaccine hesitancy. So how do we overcome that? Well, we have to overcome that by, one of the things in the American Heart said, you have to meet people where they are,
Mm.
and you have to really engage. And so I'm sure, like you, I got my vaccine, I got my second shot, had a little bit of a sore arm, but this is something that is so vitally important. And today I'm sharing on this podcast, but another week from now, I'll be speaking to teachers because we need to get kids back into schools.
Yes.
And it's a real challenge, but there are concerns. Well, gee, I know we didn't necessarily tee up about the vaccine, but I think it's a good example of how having those partnerships and having those conversations, especially bringing in the influencers in the community. And those could be members of the lay public, obviously the pastoral ministries and so forth. But even those of us who are members and communities of color really need to step forward. This is the moment when we have to basically bridge that bridge.
It really speaks well to, it's easy to say that we move at the speed of trust and that we need to build these trusting relationships. But I want to digress. It's my turn to digress. I've known you
It's
for a
your
number.
show.
That's just, this is our conversation. We can do what we want.
Yeah.
I've known you for a number of years, and I think of you as a kind and caring individual. But I want to ask you, Dr. Benjamin, you had mentioned that person came up, this young man came up to you and said, I want to hold your hand. And obviously you moved him to do that with you. But I want to ask you, how did that change you?
So, what a incredibly insightful question. I think it changed me because I'm actually telling you that story today.
Yes.
And it changed me in a way to say, this is no longer about me.
Yes.
Now, we all feel that at some point in time, but this is no longer about me. And I am a big fan of paying forward.
Hmm.
And so that engagement, that type of engagement, is one for which we all have had a chance to be at the table. We're helping to set the agenda, but we really need many more others to be drum majors of justice.
That's powerful. Um, I can't help but think that if we all we're those drum majors of justice, even in our own small way, that we couldn't help but build a more equitable society.
It's without doubt the challenge of our times. After George Floyd, Breonna Taylor, the engagement around Black Lives Matter, I think that there has also been something else that I've noticed, even within our own organizations, which is um, a commitment to being an anti-racist organization.
Mm.
Now, what that means and how we can get there, some people will say, as you pointed out earlier, that racism doesn't exist. Some people may even push back from that.
Mm-hmm.
But these are very difficult conversations to surface, let alone beginning to start uh, actively engaging with the part related to solutions. And I really think we have to work at creating that space for people. You have to really meet people where they are. And I think that it means that there is a lot of effort, not only for those of us who are identified in any particular group, but I think that part of what we have to sell it is that this is good for all of us, right? This
You
is
raise such a strong point. And on this show and in other spaces, we've talked about the inequity that exists in communities of color. And we often struggle with the linking of things like heart disease and brain disease to this idea of the social determinants. But yet we know that there is a lack of investment, there is a lack of access, there is a preponderance of tobacco that goes on, and the marketing of tobacco products to Black and brown communities. The idea that alcohol contributes to cardiovascular disease, the fast foods that are ubiquitous in those neighborhoods. How can we do a better job with, I'll just call it the neighborhood cardiologist, and this idea of equity in communities of color?
incredibly important question, and I'm going to perhaps give you an answer that is not, if you will, um, a safe one. I think we just have to disrupt the way we deliver care.
Mm.
I think we've got to be much more engaging with additional members of what really will constitute an effective therapeutic relationship. The role of the community health worker.
Mm.
It could be a he, it could be a she, but that person who is really able to engage with that other member of the community in a way where there is trust, but there is also going to be accountability. And they will do it in such a way in which they can continue to keep their eyes on the prize because there is mutual respect and trust. I think we really have to think about these, well, for now will be considered non-traditional models, but imagine those resources are in those same communities. Even if you say that they're health equities, there are resources of individuals within those communities who can be part of that broader relationship. And so the practice of medicine that we do now is very episodic. You know, it's you have a problem, I take care of a problem, and it's a transaction. But I think that if we take a more community-based approach to medicine, and I just will say that more effort needs to be placed on prevention. And the commitment to
Absolutely.
prevention therefore means that, you know, we have to basically bring others who can really help to achieve those goals. Because by the time many years of high blood pressure, and I've obviously shared with you some of those consequences, heart failure, these are very, very late events that are incredibly impactful, both at the level of the patient and their family, but also for the healthcare system in general. More time and resources in prevention, I think, would be extraordinarily helpful and impactful.
I love this idea of disruption. And frankly, the conversations that I have with individuals, including you, are often not safe, but it's just you and I talking. So nobody's listening to us. But this idea of disruption and a team, which includes community health workers, which come from the neighborhoods, I really want to ask you about this, because how do we then, because you're really talking at the ground level, boots on the ground, shoes on the ground, into the neighborhoods, to be teaching about self-monitoring blood pressure, to be teaching about medication management. I heard one of your colleagues say once that we have plenty of hypertension medications and they're darn cheap, but yet we have trouble getting people to take them. The idea that we can have diabetes education in the neighborhoods. You're saying something that is that disruption. And if you can imagine, if we had a cadre, an army of people out there, that we just might be able to make a difference.
This to me is perhaps the single most important challenge we have. And I'm going to make, I'm going to profess that I don't have all the answers. In fact, you know, a common refrain when I'm speaking with patients about exercise, I say, you know, the American Heart Association says you should just walk briskly each day for 30 minutes for 6 days, and please take one day off. And then I will also say, I am not looking for perfection. Just work with me to make progress.
Mm.
Let's make progress. I am not looking for perfection. And the point I want to make here is that, you know, as adults living in a free society, we really can't get to the stage where somebody really has to come after you just to make you do something. I mean, I think that we want to know that people have choice. And at the same time, what we want to know is that people are making healthy choices.
Mm.
And so given option A versus option B, you know which is the better of the two. And there's a science about getting people to really be able to make those choices. Certainly every time you turn on TV and you see an ad, there's a science to that.
Yes. Oh, yes.
Getting you to make one particular choice. So we really have, and you know, I really want to go back. I really think that those of us who, for example, um, find ourselves still being able to exercise frequently, these are many habits that we began and we kept them. And so we've got to make it easier that education around health in schools could be the kinds of habits that then become lifelong habits. That is an area where I think it will be so much easier for all of us if we can really work on embedding lifelong habits, the earlier we can. Now, there are some people who are listening to us who say, well, did I hear Dr. Benjamin say that now that I'm 50 years old and I've not been exercising for 10 years, that I get a pass? No.
No.
The guidelines is go check with your doctor. Maybe you'll do a stress test, and by all means, get comfortable shoes on 30 minutes a day. You should be able to briskly get your heart rate up, take one day off again. This is all about making progress. It's not about perfection.
Well, let's make progress. I like that. Dr. Benjamin, we didn't talk about this, but I'd like you to talk about some of your programs that you're working on in the community. Some of the things that really stand out for you as this idea of making progress. Is there anything that you want to tell us about?
Well, yeah. So one of the areas that we're particularly interested in is in a whole new area called cardio oncology. So we've got life-saving cancer medicines that obviously are taken to either eliminate or basically contribute to improve health. But yet there are side effects of certain cancer medicines that cause cardiovascular problems. And so we're very much interested in better understanding how maybe risk factors for cardiovascular disease, you see, can increase the side effects of certain cancer medicines. And so being able to screen members of our community who may fall in those high risk groups is an area of important research for many, myself and many colleagues within the Cardiovascular Center. And yet others are using interventions such as exercise. So these are certainly community based programs. An area where we would love to really be able to get back to, and we did work on, is in the area of hypertension control.
Mm-hmm.
And as you know, at least there's proof of concept that if you were to engage, let's say, with African American men as well as women who are coming to barbershops and salons, and if you're able to embed those spaces with a pharmacist, then getting medications in a place where people go quite frequently might be ways that we are able to impact blood pressure control. Now, COVID did put a little bit of brakes on that, but hopefully in the ensuing months, we can, or we might be able to, I hope we're able to get back and start those community-based programs because they're so vitally needed.
I love that innovation, the idea of pharmacy and cardiovascular health and the issue of being in barbershops and salons. What a fantastic idea.
Well, I must say that it's not original. I mean, these are ideas that have already had proof of concept in Los Angeles. There are many other cities. It actually goes back for quite a while. But again, this is part of just, if you will, widening the circle of influencers, you see, because we've got to basically meet people where they are in order for us to basically have a healthier society.
All right, so you get to do this. All right, so it is now you are the cardiovascular czar. You get to say anything you want to these two groups. And I love this phrase, let's make progress. What would you say to community? If you said to community, let's make progress in cardiovascular health, what would you have people do?
The single most important thing is to identify. It could be a member of your own family. It could be a neighbor. It could be a best friend. We all don't have to do this alone. And in every individual, you kind of know a little bit about what the issues are, but you need a little bit more encouragement to say, I'm gonna do something about this. I'm gonna, I know I gotta get my movement in. I know I need to get my exercise in. I'm gonna get a girlfriend. I'm gonna figure out what I have to do to care for myself. And it's when we start seeing that we're not in this alone, it makes the journey so much easier.
I love that, the idea that we're all in this together. Okay, you get to say the same thing as the cardiovascular czar to say, let's make progress. What would you say to cardiologists and to the medical area as well? How do we make progress in those areas?
The mere fact that within our medical societies, including the American Heart Association and the American College of Cardiology, that social determinants of health is part of the medical encounter. That says that you're not merely writing a prescription, but we're going to be able to impart holistic care that is the right thing around social justice in the 21st century.
What an amazing answer. I love that. And let's see if we can make that come to fruition. I want to ask you this question, Dr. Benjamin. What gives you hope?
I would say, I'll tell you a quick story.
Please.
I was, it was on North Avenue. I was just leaving my my laundry, drop off my laundry, and I was driving, somewhere there in Wauwatosa, and it was a few months back, and I saw this young kid. It happened to be a young white kid, and he had a sign in his hands. It was even taller than him, and at the top of the sign it had BLM, and he was just he was trying to keep up with the adult because they were going to go and be at the corner, I guess, of North Avenue and Wauwatosa. And I looked at that and I said, I have hope. I would say that, I am hopeful because of the young people. I am hopeful that their engagement and their willingness to be vulnerable and to engage with others. Now, I don't want to read more into that than what it is, but this is not an issue. This is an issue, whatever it is in our challenge, all of us have to be engaged and involved. And what gives me hope is there is a willingness of so many from all sectors of society being able to say, we've got to fix injustice. This is not something that is going to be pushed off anymore. The young generation are leaning in, and that gives me hope.
I think your mom would be proud of you.
Well, thank you for saying that. Hopefully she's somewhere. Thank you again.
You're welcome. Anything else you want to tell us today, sir?
I would just like to say what an amazing ministry. I don't know if that's the right word, but I think it conveys, it takes a special person to do as much as you're doing. I've really enjoyed speaking with you. I wish you well. Even on our Zoom call here, you look well. And yes, I can only say that it's really been a humbling and a privilege to join you here, Dr. Nelson.
Thank you. The pleasure was mine, Dr. Benjamin. Dr. Benjamin, thank you for coming on the Days of Learning podcast. We look forward to seeing you again in the future, and I just love your story, sir. Let's keep making progress.
We will keep making progress. Thank you very much. Bye-bye now.
Bye. Oh, what a great interview. Dr. Benjamin really spoke a language that we have heard here on many occasions on the Days of Learning podcast. He talked about the idea of his own journey in cardiovascular health, as well as what he sees at the Cardiovascular Center, the work that he does from the molecular to the community. But I think he highlighted some very important concepts that will resonate with many of our listeners, as well as link to many of the other shows that we've had. This idea that we need to connect with the community and to collaborate with the community on issues like social determinants, health equity, and even structural racism as a way to supporting cardiovascular and brain health. You know, he talked about these opportunities for collaboration, whether it be utilizing community health workers or doing such things as having people like community health workers working on self-monitoring blood pressure, working with pharmacy, as well as diabetes education. All of those things go into the health of our community. Dr. Benjamin really is an inspiration for all of us, and somebody that is really, he walks the walk. So for the Days of Learning podcast, I am your host, David Nelson, and thank you for joining us.